Hello, my name is Martine Sanin, and I will be presenting this talk on the hazards of hospitalization. In this slide, I've listed our learning objectives for this presentation. By the end of this talk, I hope that the learner will appreciate the challenges of caring for the older patient in the acute care setting, recognize some of the common hazards of hospitalizations, and understand which older adults are highest risk for developing them. I will review measures that can help minimize an older adult's risk of developing hazards in the hospital and introduce the geriatric 5M framework and assessments, which may alter and improve patient outcomes in the acute care setting. We know the hospital can be an extremely frightening place for older adults. Older adults tend to be hospitalized 3 times more frequently than our younger counterparts and have longer length of stay. Their severity of illness is also often greater and associated with greater morbidity and mortality. For our vulnerable older adults, the stress of a hospitalization can often precipitate a cascade of events leading to a decreased healthcare quality of life. It is important that we recognize these risks and implement preventative strategies to keep our patients safe. To review some of the challenges with hazards of hospitalization, I'm going to walk you through the case of our patient, Mr. H. Mr. H is an 84-year-old male with a history of hypertension, congestive heart failure, hearing loss, and mild dementia. He was brought to the emergency department by his daughter because he was complaining of a fever, cough, and just generalized weakness for several days. Prior to his illness, Mr. H was living alone. He's independent with his activities of daily living and instrumental activities of daily living. He was not a drinker. He was a former smoker, but quit over 30 years ago. Listed here are his medications that he takes at home and manages on his own. Lisinopril, 10 milligrams, metoprolol, 25 milligrams BID, furosemide, 40 milligrams daily, glipizide for his diabetes, and gabapentin. On exam, he's slightly hypotensive with a blood pressure of 100/80, a heart rate of 65, and febrile to 38.5 degrees Celsius. His oxygen sat is 95%, and his weight on admission is 130. He's awake and alert and oriented ×3. His cardiac exam is regular with no murmurs. His lungs is notable for crackles at the right base, but no wheezing. His abdomen is soft and non-tender, extremities no edema, and the rest of his exam is unrevealing. His basic blood work done on admission is notable for a complete blood cell count with a white blood cell count of 14 with 85% PMNs in left shift and a creatinine of 1.9. His glucose is 71. And on the right is his chest x-ray, consistent with what we heard on exam of a right lower lobe consolidation. So Mr. H is admitted and the treatment plan is initiated. He started on antibiotics for community-acquired pneumonia, ceftriaxone and azithromycin. Because of his hypotension and his fever, he started on some IV fluids and his antihypertensive regimen is held. We're going to take a closer look as to what happens during Mr. H's hospital course. On hospital day 1, the night float intern is called to see the patient because he was agitated. He's appropriately assessed and found to be hypoxic now to 85%, and his blood pressure hypertensive 170/90. Because of this new hypoxemia, chest x-ray is ordered. IV fluids are DC'd with the reading consistent with pulmonary edema. Mr. H is given some additional IV diuretics, and a catheter is placed to ensure adequate I's and O measurement. Is placed back on oxygen, now requiring 2 liters. By day 3, because the patient still has a Foley catheter and the oxygen, He's often trying to pull it out and sometimes getting confused trying to come out of bed. Unfortunately, he's placed on restraints, 2-point restraints, and an order for lorazepam is placed as needed for worsening agitation. By day 5, Mr. H tries to get out of bed because he's persistently agitated, and unfortunately, he falls and pulls on that catheter. Urology now is consulted to replace the catheter as he was bleeding from the urethra. Finally, day 8, we were able to remove the restraints as the patient now requires a sitter, as he's still intermittently confused. A urine culture is done after the Foley was placed, now growing E. coli, and he's required to start on antibiotics. His confusion still persists, and at this point, he's intermittently alert, and this is assumed to be his new baseline, as some of the team members felt that Mr. H may have had some dementia. Because of his confusion and to help control some of his agitation, he started on Haldol, 1 milligram BID. We now fast forward to almost day 12 of his hospitalization, where Mr. H has been mostly bedbound and now has developed a pressure injury. He's also significantly debilitated, and after working with physical therapy is recommended for subacute rehab after discharge since he's unable to ambulate on his own. Mr. H transitions to the subacute rehab, and despite 3 weeks being there, he's unable to recover his ability to walk and is eventually transitioned to a long-term care nursing home. What do you think happened? What might have contributed to Mr. H's decline? What caused this otherwise healthy man to end up in a nursing home? Mr. H's story is unfortunately all too common, and this is a decline that happens in the hospital, separate from what his initial diagnosis was. If we take a closer look, and you see here highlighted in red, are the examples of all the hazards that poor Mr. H felt or encountered during his hospitalization. All of these also represent areas that we can intervene on to prevent from these outcomes from happening. When we think of hazards of hospitalization, we're referring to complications of a hospital stay unrelated to the problem that caused the admission or to its specific treatment, and both that are explainable and avoidable. There are a number of reasons why hazards or hospitalization can happen and why our older adults are at greater risk. We often think about it as an intersect between the predisposing risk factors of that vulnerable older adult and the precipitating factors also deemed as hospital-related stressors that lead to this unfortunate disability and increased morbidity and mortality that we're seeing. This image or schematic is reproduced from Creditor's Annals of Internal Medicine article titled Hazards of Hospitalization. It reminds us of that interplay, that usual aging, which is associated with changes in normal physiological changes that increase the susceptibility to various stresses. Some of the changes represent a reserve in function that will not present or produce a disability under normal circumstances. However, in a vulnerable older adult, when they are stressed, as we see in an acute hospitalization, we begin to see this unfortunate decline due to these stresses and a decrease in their physiological reserve. This state of imbalance leads to this unfortunate cascade of functional decline. In the next few slides, we'll discuss the various domains of hazards of hospitalization and recognize that they often begin immediately and progress rapidly. The first is cognitive decline. So delirium is one of is a very common geriatric syndrome that we tend to see in our older hospitalized adults. The DSM-5 definition reminds us of what delirium is: an acute confusional state, often led to by the disturbance of consciousness and a notable shift in attention. And this change may continue to wax and wane and fluctuate during the course of the day or hospital course. And it is not thought to be due to an evolving dementia. There is often history from their physical exam or lab findings that this is a consequence of a general medical condition. We know our older adults have a number of predisposing risk factors for delirium. Namely listed here, their advanced age, their dementia, their baseline activity of daily living and impairment, the fact that these patients have high level of medical comorbidity, some baseline sensory impairment, vision impairment, hearing impairment, dehydration, or the sheer nature that they are sick in the hospital. But it's also important to recognize what can precipitate a delirium and have a broad differential in terms of ruling out things that can be reversed. So taking a look and using this mnemonic confuse, ruling out any sort of acute issue related to the central nervous system, baseline organ dysfunction, so that acute renal injury or dehydration, nutritional deficits, a new infection, metabolic derangements, and fluid and electrolyte abnormalities. For our older adults, this may also include urinary retention, severe constipation, and fecal impaction. Paying specific attention to certain endocrine disorders, sensory deprivation that tends to happen in the acute care setting, and even drugs or the withdrawal of medications that the patient is typically on. This schematic is reproduced from Sharon Inouye's earlier work on delirium in older persons, reminding us of the multifactorial model of delirium. Delirium is usually multifactorial, this complex relationship between that vulnerable patient and exposure to precipitating factors or noxious insults. In this case, we identify that a patient with multiple predisposing risk factors or is deemed highly vulnerable, it will take a less noxious stimuli to precipitate a delirium. Likewise, that patient with low vulnerability, few risk factors, it'll take a pretty severe and complex medical condition to precipitate that delirium. Once you've recognized the risk factors, especially in your older vulnerable adults, it's important to implement non-pharmacological interventions, especially for a high-risk patient like Mr. H. It is easier to prevent delirium from becoming an issue rather than trying to chase it after a patient has developed acute delirium. Listed here are some common interventions that can be implemented on day one of hospitalization, reminding family members and staff to provide that redirection and reorientation if a patient appears confused, being mindful of the environmental stimulation and things that we can do to mitigate that risk, minimize sensory impediments, take advantage of orientation cues available. Can a patient be by a window? Do we have the proper date and time on the calendars and clocks? Who are the caregivers around the patient, and remind them that they are vulnerable, and things we can do to reorient and redirect them. Be mindful of our medications that we're ordering and avoid inappropriate medications, in particular high-risk medications such as anticholinergics, antihistamines, or benzos. Avoid restraints whenever possible, and recognizing that some medical interventions are often seen as restraints. Things like the nasal cannula and the Foley can actually increase the risk of falls and injury and delirium. You're only going to use restraints as a medical emergency, and if so, as a short duration, with the intention to frequently reevaluate the need and discontinue as soon as possible. Another important point that I like to emphasize is being mindful and screening for delirium. The gold standard for screening delirium is the confusion assessment method. And it has been validated in various clinical settings, including a brief CAM for the emergency department and the ICU CAM for the intensive care unit setting. It is important to recognize that without using a validated tool to screen delirium, nearly 40% of these cases can be missed. The CAM takes into account the first two features, that there is an acute change in a patient's mental status and that it may fluctuate and wax and wane throughout the day. Number two, that there is some level of inattention. And finally, one of the other two features, is there some concern of disorganized thinking or an altered level of consciousness? Again, the CAM should be part of that bedside evaluation, and it can fluctuate throughout the day. But without using a standardized tool, nearly 40% of these cases can be missed. A number of studies have looked at the implications of hospitalization on cognitive decline. I've listed here several studies between 2010 through 2018, which have looked at hospitalized patients in a population of older adults who've either developed dementia post-acute hospitalization, have seen an acceleration in cognitive decline after a hospitalization, or cognitive impairment, or especially after a course of ICU delirium or an acute hospitalization with severe illness. And in terms of delirium, this has been replicated in studies. We know that delirium, often deemed our medical emergency, is an independent risk factor for increased mortality, worsening hospital complications such as falls, infection, prolonged mechanical ventilation, long-term loss of dependence in your activities of daily living, and more complex discharges to post-acute care facilities with underlying long-term cognitive impairment and even post-traumatic stress. So it is imperative that we identify those risk factors, implement strategies to prevent delirium, and recognize the long-term implications it has in a patient's healthcare trajectory. The next domain we're going to talk about is that functional decline, often seen as a hospital-associated deconditioning and also the risk for falls. Older adults in the hospital tend to lose strength at a rate of 3 to 4% in general. When you add the amount of decline related with bed rest, you'll see that older adults can lose up to 5% of muscle strength daily just by laying in a bed. Hospitalization has been associated with an irreversible decline. Nearly 30% of our older adults will lose 1 or 2 ADLs at the time of discharge, and nearly 40% of declined instrumental activities of daily function at 3 months after discharge. And in fact, there's data to support that patients discharged from a hospital with a new ADL disability often do not recover even after 1 month to return to their prior level of functioning. And in fact, this study also looked at 1-year mortality. It's almost twice as high as those discharged with a decline from their baseline functional status. So again, long-term implications with the hospital-associated debility seen after an acute hospitalization. This poor functional performance in older adults is a growing concern. Medicare spending for post-acute care after hospitalization has increased significantly in the last decade, representing nearly 10% of our Medicare budget. And despite this spending, nearly 68% of patients are discharged from even a post-acute care setting below their pre-hospitalization level of function. This leads to nearly 1 in 5 Medicare beneficiaries re-hospitalized actually within 30 days after their acute hospitalization. And then you have to think about frailty as another very common geriatric syndrome, which can impact outcome. Frail older adults experience higher rate of adverse health outcomes. And more recently, especially in the surgical patient population, we are looking at tools such as the clinical frailty scale that can be implemented in routine practice to better stratify our patients and help guide and assist with clinical decision making in the acute care setting. In the next slide here, we review falls and risk factors for falls, which is, again, a common geriatric syndrome defined by a number of predisposing and precipitating factors. We know that nearly 30 to 50% of older adults will have a fall, and after the age of 75, the rates and severity of falls will increase. Many adults also report the fear of falling. However, specifically for hospitalized patients, while we're often looking at both the intrinsic and extrinsic causes leading to a fall, this hospital environment can be triggering and places our older patients at greater risk. Whenever there is concern of an alteration of consciousness, this acute confusion or delirium, an individual who's had a history of fall and at risk for certain medications, these are things we need to really pay particular attention to also while an individual is in the hospital. For individuals who meet high risks for falls, it's important to, even when they're in the hospital, assess for their risk of falls and acknowledge that restraints do not necessarily decrease falls, but may lead to increased deconditioning and injury. Should also be mindful to develop care plans to decrease and identify the risks. Look at those medications, in particular the high-risk medications, which have been implicated in confusion and in falls, things like anticholinergics and sedative hypnotics and benzos. Work with the care team in the hospital using multimodal approaches on education and how to reduce and minimize the risk of falls, and take advantage of using remote patient monitoring if your hospital has it. There should be also an individualized approach to preventing falls, purposeful hourly rounding, understanding what the patient's baseline was prior to the hospitalization such that they are not limited to bed rest and precipitating that functional decline. And more recently, it's also been documented from CMS and Center for Medicare that hospital-associated complications have been associated with individuals with more cognitive impairment, history of prior falls, and of course, individuals with medications that have a higher anticholinergic burden score. So things to be mindful of and putting in preventative strategies for these patients. Lastly, the last domain that we will approach is iatrogenic complications that are unfortunately very common for our older adults. And this includes things like adverse drug events, malnutrition and dehydration, pressure ulcers, and hospital-acquired conditions. Here, I will review how, again, the interplay of predisposing factors in our vulnerable older adults combined with the stressors of hospitalization can lead to these unfortunate consequences. So the first is looking at adverse drug events. Older adults are uniquely vulnerable to adverse drug events, and this is often compounded by the hospitalization as medications are added and adjusted. Polypharmacy is common in our older adults, affecting nearly 40% of them, and 30% of hospital admissions in older adults can be linked to drug-related problems or drug toxic effects. This includes drug interactions, side effects, the inappropriate use of a medication, or the inappropriate dosing of a medication. The most frequently implicated classes of medications include are non-steroidal anti-inflammatory drugs, also known as NSAIDs, certain antibiotics, which have to be monitored for an individual's renal function or liver function, high-risk anticoagulants and blood thinners, diuretics, hypoglycemics, beta blockers, calcium channel blockers, and several chemotherapeutic agents. The consequences of adverse drug events is broad and can span from the patient level to from temporary injury or an error to really critical illness and death. And this is something that we need to really pay particular attention with our high-risk older adults. And again, referring back to that geriatric prescribing mantra of starting low, going slow whenever new medications are introduced. It's important to also recognize why our older adults are at greater risk. They typically tend to have more than 6 chronic conditions. They tend to be prescribed more medications. So often, more than 5 medications is already considered polypharmacy. Individuals who've had a prior adverse drug event are also at greater risk. And then looking physiologically at that patient, the older the patient, over the age of 85 with a low BMI, or some compromise in their renal function puts them at greater risk for adverse drug events. Polypharmacy is not necessarily avoidable, especially with people living longer with chronic conditions, but it is important to be mindful of things that we can adjust for to ensure that they're getting the safest in terms of medications. The other thing to consider, in particular for inpatient management of medications and when a patient is ready for discharge, is how that older adult is taking their medication. Are we mindful and know to call the pharmacy and confirm if the patient has it in a pill box or a blister pack, and what changes are we discharging our patients on? Did we identify any changes and adjustments based on the renal dosing? And after hospitalization, just also be mindful of potentially inappropriate medications that we may be able to deprescribe or alter. While adverse drug events during a hospitalization are serious and yet preventable, um, there are a number of things that we can do better. In this study, they looked at an intervention, which actually looked at a geriatric prescribing context, right? Really to mitigate the risks of, prescribing practices in older adults and the impact of adverse drug events. And certainly by utilizing an electronic medical record that can risk adjust for our older adults, this program was able to reduce the number of dose-related adverse events seen. The next domain I want to touch upon is malnutrition and dehydration. Malnutrition is highly prevalent in our older adults and has a significant burden. If you think back to some of the physiological changes, with age, the sense of taste decreases. In the hospital environment, the food is often less appetizing and tasteless, in addition to the restricted diets that we often place on our patients. Nearly 25 to 30% of hospitalized older adults are actually undernourished and malnourished, and it is a strong negative predictor for clinical outcomes. Appetite and nutrition at baseline tend to decrease with age, and so we also should be mindful of the need for these NPO orders. Nothing by mouth for procedures that a patient may or may not have has significant implications for older adults who tend towards intravascular dehydration. A few things to remember is that thirst is less for the degree of hyperosmolarity. As you age, renal concentrating ability is often impaired, where salt wasting is more common. So being mindful of these orders is extremely important and not to delay resuming a diet for these patients. Studies have also shown that malnutrition has serious implications for recovery from disease and is associated with increased morbidity and mortality, in addition to longer hospital stays. The mini nutritional assessment tool is a practical and actually rapid nutritional evaluation that can be done that can help predict Predictors of poor outcomes in our older adults and allow you to identify malnutrition early and implement strategies while a patient is in the hospital. Furthermore, another study that was published in 2023, a meta-analysis studying the risk of rehospitalization in malnourished older adults, concluded that malnutrition is often overlooked and has detrimental adverse effects. In fact, 30-day rehospitalization increased in patients with malnourishment, and mortality and hospital length of stay have been associated with malnutrition. The next domain we'll touch upon is pressure injury and skin breakdown. Pressure injury is among one of the most common conditions suffered by our patients with prolonged hospitalization and bed rest. A pressure ulcer, as you recall, is a localized skin erosion and subcutaneous crater, usually over a bony prominence, and caused by mechanical effect of unrelenting pressure. Like all of our geriatric syndromes, we've grouped them into intrinsic and extrinsic risk factors. The extrinsic ones are typically the pressure of simply bed rest and the shear, friction, and often moisture for patients who are immobile. And intrinsic risk factors is that immobility and advanced age, poor nutrition, dehydration, and incontinence, which can lead to worsening skin injury. The prevalence of pressure injury in our older adults can be as high as 40%, and can continue to get worse with just sheer skin necrosis and prolonged immobility. And while many are considering pressure injuries as a long-lost geriatric syndrome, this is highly prevalent and multifactorial and needs a multimodal approach to prevent, and should really be recognized in our patients at high risk, those with advanced age, increased frailty, dementia, and multiple chronic comorbid conditions. This is a reminder of what staging looks like for our pressure injuries. As you recall, stage 1 is intact skin with non-blanchable redness, while a stage 2 shows a partial thickness loss of the dermis. A stage 3 is defined as more of a full thickness tissue loss, with subcutaneous fat may be visible, but bone, tendon, or muscles are not exposed. And when an injury or pressure injury is at stage 4, there is a full thickness loss with exposure to the tendon or bone. Other types of injury described are deep tissue injury, where there is a purple or maroon localized area, or a blood-filled blister due to damage from the underlying tissue, or unstageable, where full thickness tissue loss and the ulcer in itself is covered by a yellow, tan, or gray wound bed, or oftentimes an eschar. It is important to recall what the various stages look like, and also important to document, especially on day 1 or early in the hospitalization, a full skin assessment to differentiate injury that was present prior to the admission, and to also prevent further decline while a patient is hospitalized. And finally, a comment on the various hospital-acquired conditions. As of 2011, CMS prohibits Medicaid payments for the additional costs or services that result from certain preventable healthcare acquired illnesses or injuries. So costs associated with some of these errors, which are considered never events, are not reimbursed by CMS, and often affects the quality and rating of the hospital care and patient satisfaction. I've listed here a few of the more common ones that we've seen, and some that have been mentioned already, and this includes the adverse drug reactions, catheter-associated urinary tract infections, vascular catheter associated infections, injuries from falls, pressure ulcers, in particular, stage 3 and stage 4, or VTE and PE after certain procedures. Again, so many of these overlap with some of the hazards already described in our case. With that said, I want to go back to the case of Mr. H. As you recall, he is our 84-year-old gentleman with hypertension, heart failure, hearing loss, and mild dementia, who was admitted for a community-acquired pneumonia and had a hospital course that was prolonged and complicated by several hazards. What can we do in the future to hopefully prevent these hazards from happening? Or what could we have done to help Mr. H throughout his hospital course? On the left, I've listed once again some of those domains and opportunities with just basic medical orders to prevent these hazards from happening. So in terms of his deconditioning and his hospital associated debility, thinking from day one, opportunities in this patient who was previously independent, orders to include him to be out of bed every day, at least 3 times a day for his meals, encourage early ambulation and early evaluation by a physical therapist to ensure that he is not becoming more and more debilitated. Assessing for falls and preventing the use of any tethers in terms of the Foley catheter, the IV, the nasal cannula, things that could have been prevented or removed as soon as deemed medically able to. If a patient has some gait instability and uses a cane or a walker, making sure that we do have these available for our patients. And again, ensuring early evaluation with our interdisciplinary team, our physical therapist and occupational therapist and nursing to mobilize a patient. Delirium, recognizing those high risk predisposing risk factors, simply the advanced age, some baseline cognitive impairment, and the acute illness. We can implement preventative strategies to reorient and redirect a patient, ensuring that he has his glasses, his hearing aids, his dentures, that he is sitting by a room with a window, and that the clocks and the orientation boards are up to date. If there is a need to use a medication to address an agitated delirium, that we're using the safer agents and not committing a patient to longstanding antipsychotics unnecessarily. Pressure ulcers. Again, being mindful of what are those risk factors for an individual to develop a pressure wound. Are they mobilizing? Are they malnourished? Are they sitting in soiled sheets? So orders to reposition and turn the patient every couple of hours and ensure that their skin is clean and dry and that they have assistance to get to the bathroom and know how to call for help. Again, adverse drug events and iatrogenics, which is very common with older adults, especially those with multiple medications and polypharmacy. So be deliberate about the medication reconciliation. Recognize the use of tools such as the Beers criteria to avoid meds that are potentially inappropriate. Be in communication with the outpatient pharmacy to ensure that the medication lists are correct and understanding how a patient gets their medications and manages them. Malnutrition and dehydration, certainly consider liberalizing their diets. Ask for help with the nutrition team and baseline assessments like the MNA, which can identify early malnutrition and add supplements as needed. Encourage PO hydration as our older adults tend to dehydrate. Assist with meals as necessary and limit the use of IVs if patients can be able to eat and drink independently. And with that said, I'd like to also conclude with the it should be the 5M framework, which is an area of focus that has been introduced to the field of geriatrics and the reframing the way care is provided. And by just thinking about the 5 domains of mind, mobility, medication, multi-complexity, and what matters most, we're really able to provide a more comprehensive approach to care and addressing not only the geriatric syndromes, but implementing strategies with the patient in mind to keep them safe. And with that said, I will conclude with some take-home tips in the care of our older hospitalized patients. One, remember that delirium is a medical emergency. You should be mindful to assess and monitor for their cognitive status. Only use antipsychotics when a patient is a danger to themselves. Avoid restraints whenever possible. Be mindful of IV lines and catheters and remove them as soon as they're no longer medically indicated. Think about their medications. The fewer drugs, the better. Review medications frequently. Be mindful of changes in their lab data. Get our patients moving. We should avoid orders such as complete bed rest. Allow the patients to be out of bed with assistance. Have a sense of what their baseline functional status is so that we can do our best to preserve it despite being hospitalized. Think about where a patient came from. What was their pre-hospitalization functional status and cognitive status? And think about what discharge planning can look like from admission. You want to pay attention to their nutrition. How much food is actually being consumed at the bedside? Do they need help to open some of the food in their tray? Is there an opportunity to work with our nutritionists to add supplements? And be mindful of those NPO orders. Is it truly indicated? When can we DC it? Involve patients and family in decision making and in advance directives, and also in acknowledging some of these geriatric syndromes and their role in preventing the worsening cognitive and functional decline. And consider the 5M framework to assess the care needs of our older adults. I have a couple of CME questions to conclude this talk. Question number 1. In the hospital, the non-ICU setting, the most appropriate initial management of delirium is 1, modify the environment. 2, limit the use of restraints. 3, pharmacological management. 4, evaluation by thorough history, exam, and diagnostics. The answer to this question is letter D, evaluation by history, exam, and diagnostics. Delirium is often the only presentation of a medical emergency and will not resolve until the underlying diagnoses are identified and treated. Medications are reserved once non-pharmacological interventions are tried, although limiting the use of restraints and modifying the environment to be more peaceful are good ways to prevent likelihood of delirium. Once delirium develops, they are not as effective. And question number 2, an 82-year-old patient is admitted for treatment of pneumonia with hypoxia. She's placed on oxygen supplementation by nasal cannula. An IV is started for IV antibiotics. She's placed on bed rest and given subcutaneous heparin for DVT prophylaxis. By hospital day 3, she is responding to therapy and shows improvement of her hypoxia. She's anticipating discharge the next day and is looking forward to returning to her home. That night, she falls while transferring out of bed to her bedside commode alone. The most likely reason for her fall is A, tethers causing an acute confusional state. B, failure to use a Foley catheter to reduce the need for ambulation. C, bed rest causing muscular deconditioning and weakness. Or D, malnutrition causing peripheral neuropathy and poor motor coordination. Again, the question is the most likely reason for her fall. The answer to this question is C, bed rest causing muscular deconditioning and weakness. Bed rest is a common precipitant of deconditioning and functional decline. The rate of decline dramatically increases with both advanced age and reduced lean body mass. As a result, muscular deconditioning is a common cause of falls in older hospitalized patients. Additionally, falls related to deconditioning are much more likely to occur in the evening. In this patient, there is no evidence to support delirium. Foley catheters are associated with an increase in falls and delirium, not a decrease, and their indirect result of decreased ambulation is unfavorable. Peripheral neuropathy is unlikely to occur during the short duration of malnutrition during this patient's acute illness. Thank you again for your time. This is my email address should you have any questions, comments, or concerns. Thank you.